Hi there, my name is Joan Harris and I'm with the ACCN program. Today we're going to be doing a video looking at the neuro assessment and specifically the Glasgow Coma scale. We're going to talk a little bit about why we use the Glasgow Coma scale and go through the different parameters of the Glasgow Coma scale. I'm here with Jake. He's our patient today and he's going to be helping us demonstrate some of these aspects of the Glasgow Coma scale. The neuro assessment is very important, and what the Glasgow Coma scale looks at is level of consciousness, which is one of the earliest and most subtle changes that we can see looking at brain injury. So it's something that we usually do a baseline for, and then we're going to do periodic assessments to make sure that there's no change that would indicate that we need to do some management of that. So the Glasgow Coma scale has three components. It looks at eyes, verbal, and motor. We're going to start with the eyes. The eyes is out of 4, and a score of 4 would indicate that the patient's eyes are open and spontaneously. So when I come up, I can immediately see that Jake's eyes are open. 3 would be his eyes are closed, but if I ask him to open his eyes or call his name, he'll open his eyes. Jake, can you open your eyes? Perfect. With the GCS, you want to use the least amount of stimulation possible. So you start off with just looking at them, seeing what they look like spontaneously without any stimuli, and then you would go to verbal, and then you would actually go to a physical or central pain stimulus. So we talked about 3, so now we're going to go to 2 with the eyes. 2 is eyes would be closed. And in order to get him to open his eyes, I would have to elicit a painful stimulus or a physical stimulus. So I would squeeze here, there's one of the ways that we can do that, and he would open his eyes in response. So that would be a 2 out of 4. The last one is that there's no response regardless of what I do. So I would again start with verbal and then go to physical, and I'd try to do some central pain, and there would be no response whatsoever. The next on the list is verbal. Verbal is looking at their ability to speak. So it's out of 5. So the best response would be that I would ask him a question and he would respond appropriately. So I'd ask, Jake, what did you have for breakfast today?
I had some cereal today.
Great, perfect. So that would be a 5 out of 5. 4 is that it would be a confused statement. So I would ask him, Jake, what did you have for breakfast today?
My pet hamster.
Exactly. So doesn't really make a lot of sense, the confused statement. So that would be a 4 out of 5. So 3 out of 5 for the verbal would be that they had incomprehensible sounds. So there may be some words, but they're not put together in anything that makes sense. So Jake, what did you have for breakfast?
I have a hamster pet.
Great. So incomprehensible. There's a few words there, but it's all muddled and doesn't make much sense. So that was 3 out of 5. Now we're going to look at 2 out of 5, which is basically moaning, crying. There's no actual words anymore. It's just moaning or crying that you'd see. So Jake, what'd you have for breakfast? Right. So that would be 2 out of 5, and then the final one, 1 out of 5 would be no response whatsoever. So I would ask him things, and there would be no verbal response. One of the things that I'll just mention in the intensive care or even in the ER, if a patient is intubated, they obviously can't have a verbal response because the tube won't let them because their vocal cords are covered. So in that case, we would just give them we mark down 1 and then usually put a T beside it. The T indicates that they're tubed, so it's saying that we're not getting a verbal response, but we can't really say that they couldn't do a verbal response. It's because of the actual the placement of the tube. The last thing we're looking at is motor, and this is out of 6. The 6 out of 6 would indicate I would ask Jake to squeeze my finger or move his thumb or something, and he would be able to do that appropriately. So I'd say, Jake, can you just squeeze my fingers here, please? Great. Can you hold up a thumb? Perfect. So he would be able to do that, and it would be appropriate. That would be 6 out of 6. 5 out of 6 would be that I would have to, he wouldn't respond to me if I asked him verbally. I would have to try and elicit a motor response using pain. And in this case, we use central pain, which I'm going to talk about in just a minute. But the 5 out of 6 would be that he would do what we call localize. So if we're looking at the patient and they're standing straight, he's going to cross over the midline and try and grab at where I'm eliciting that painful response. So I'm going to be squeezing here, and he's going to try and get that away from me. So he has to, it's not just a withdrawal, but it's actually localizing to the area of stimulation. That's 5 out of 6. 4 out of 6, we're looking at the withdrawal response. So you elicit pain, they can't figure out where it is and they don't try and pull your arm away, but they do know that something's not right and they'll be pushing. So if I went like this, he's not going to be able to pull my hand away, but he's going to make a response that something's yucky and he doesn't like it. So that would be 4 out of 6. 3 out of 6 is what we call flexion, or abnormal flexion or decorticate. And in that case, when I elicit the painful response, his arms are going to come up in a flexed way and the toes are going to be extended. So I'm just going to be pulling back here so you can see what the feet do. Okay, so his eyes are going to be closed because he's not responding. I'm going to go like this, and arms are going to flex up, toes are going to flex down. Perfect. So that would be a abnormal flexion response. So that's 3 out of 6. Now 2 out of 6, we're going to look at extension, abnormal extension. In this case, the arms are going to come up and rotate inwardly, and the toes are going to extend again. So eyes closed. I'm going to elicit the response. Right. So you see that the toes are still extended, but now the arms, instead of being here, are actually up here. And that would be 2 out of 6, and then 1 out of 6 would be no response whatsoever. I just wanted to talk a little bit about the types of painful stimulation. We always try to do central stimulation in order to make sure that we're actually getting a indication of whether there's a lack of brain function. And I'll talk a bit more about peripheral stimulation in a minute. There's several types of central stimulation that you can do. One is that you've been seeing me do throughout the video here so far is what's called the trapezius squeeze. So you're going to be squeezing at the top here. I'm not going to do it hard because it's very painful, but that would be one of the options. Another option is to do what's called the orbital. So you're actually taking your thumb, there's a little bit of a groove here towards the nose, and you're going to press really hard in there. Another one is mandibular, and you're going to go at the angle of the jaw, and again, press really hard there. And those are 3 common ones. Another one, which may or may not be done in your particular institution, is called a sternal rub. So basically, you're going to take your knuckles and rub on there. The thing to consider with all these things is that they are painful. These ones tend to have less potential for bruising, whereas the sternal rub can cause bruising, and so may or may not be the best option depending on how frequently you're going to be having to do your neuroassessments. That's central stimulation. Peripheral stimulation can also be used. One thing to keep in mind with peripheral stimulation is that you could potentially just be eliciting a spinal reflex as opposed to like indicating that there's a change in the brain function. To do peripheral stimulation, I'm just going to use Jake's hand here. One of the things that we want to make sure we don't do is use the nail bed. So a lot of people will take a pen or something and press on the nail bed. There is that potential to do some significant damage there. If you're going to be doing it that way, you would prefer to do it on the bone, just between the knuckle, as opposed to the nail bed. Another option that is even better is to actually just squeeze the fingers together. That way you're not actually less likely to cause tissue damage. So those are, and you can do the same on the feet with the toes as well. So either one of those would be ways to do peripheral stimulation.